My name is Mike Preston. I'm a client partner with Healthcare Triangle. We are a professional services firm that is passionate about moving everyone to the cloud as quickly and as efficiently as possible. You can't hear me. Welcome to our last session of the day, our closing keynote session titled Digital Health and the Frontiers of the Opioid Crisis, presented by Dr. Alister Martin. Dr. Martin is faculty at MGH, or at the MGH Center for Social Justice and Health Equity at Harvard Medical School, and the founder of Get Waivered, a campaign aimed at transforming EDs nationwide into the front door for recovery for patients with opioid addiction. This work serves as a national model at the NIH with several state partnerships, including Get Waivered Texas and Get Waivered Nebraska. His work has been written about in the Boston Globe, NPR, and JAMA. And he just left a senior advisor role at the White House Office of the Vice President. Please join me in welcome Dr. Martin today.
Thank you, Mike. Listen, first of all, I know that I'm the only thing between you all and the open bar a little later. I also happen to know that there's a minimum spend that we've got to hit on the alcohol. So we really kind of got, if people want to get out there now and get a shot now, I won't be offended. Honestly, I really won't. My name is Alister Martin. I'm an ER physician. And today I'm going to tell you a familiar story. And it's a story of how digital health saves the day. But it's also a story of the work that we have to do to make sure that digital health does not widen pre-existing disparities, which we all know to exist already. But before I tell you about all that, I want to transport you in time. The year is 2016. The Brexit vote has just happened. Justin Bieber drops a new album. It's a banger. Total banger. Love Yourself was on that album. Very good song. And everyone's favorite moment, highlight of 2016, Pokemon Go, the app dropped and ruined everyone's life for a couple of months. And little old me, I was a intern in emergency medicine in my first week of my first year as an ER doctor. And I had a young woman who came to see me in the ER. It's a Friday night at 4 a.m. And she told me a story. She said, "Doctor, I am a mom of two. And about 6 to 7 weeks ago, I fell down the stairs at my son's daycare. And I broke my ankle." She had a nasty left ankle fracture, an open ankle fracture. And she had to go get a complicated surgery. It's called an open reduction internal fixation, massive surgery. At the other hospital, after she was discharged with oxycodone, the first time she'd ever taken opioids before. And what she felt after a couple of weeks was she felt like she could just not feel normal after taking the medication. She felt like she needed it. She'd run out of the prescription she got from the doc in the post-op period. But she knew that her husband had some leftover tablets from a previous injury that he had. So she searched the kitchen cabinets and cupboards, and she took those pills. She ran into those. She eventually found friends and family members and bummed some pills from them. Things had gotten so bad that she went back to her hometown. She knew a guy. And she started getting this former friend of hers to prescribe, to write her or to give her medications illicitly. He was a dealer. And that night she had decided that this had gone way, 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 way too far. She had never, ever, ever thought of this being her future. She'd never signed up for this. And she texted the dealer, this person that she knew from her home. And she said, "Look, I don't want to do this anymore. I'm getting help. Lose my number." She even showed me the text message. I'm still getting chills thinking about it now. The dealer responds back, "No problem. Good luck." About an hour later, she hears a knock at her door. She goes downstairs. It's her dealer. Her dealer says to her, look, recovery's hard. And, you never know what's going to happen. And so I think you should take a couple of these for the road. He gives her 10 teal oxycodone tablets for free on the house. Her husband, who was unaware of this whole situation, sees this interaction and intervenes. And he comes downstairs, and they have the first confrontation about what has been going on. And it's now Friday at 10 p.m. They get online, they try and find a recovery treatment center, an addiction program. This place doesn't take her insurance. That place doesn't have time for the next 6 weeks. This place shut down a long time ago. They're at their wits' end. They decide, you know what? Let's just go to the ER, where they see me, little old Dr. Alister Martin, who is still green behind the ears, has literally no idea what he's doing. But I do know that I work at Mass General Hospital. For those who are here in Massachusetts and perhaps Boston, what do we call MGH? What's the nickname? Hey, can you say it a little louder?
Man's greatest hospital.
I said, we're at Man's Greatest Hospital. Of course we're going to help you. She says, Doc, can you help me? I've been trying to find places to go. And I didn't know where else to go, so I came here. And I'm thinking, well, we're at Man's Greatest. Of course we're going to. No problem. I said, sit right there. Don't worry about it. We're going to take care of you. We're going to figure this all out for you, okay? I go and walk back to go and talk to my attending. For those of you who are not aware of how it works in an ER, the residents may come up with the plans, but the attendings have to actually say, yes, this is what we should do. Let's go forward. So I tell my attending, who, by the way, is a kind, very intelligent, compassionate physician, okay? I say to him, look, we've got this young woman. She's in her 20s. She's got 2 kids. She got addicted to opioids, but she's self-presented. She wants help. Let's get her admitted. Let's get her an addictions consult, and let's help her get her life back. My attending looks at me, and he says, Alister, that's just not what we do here. Discharge her. That walk back from my attending's desk to her room is still to this day one of the longest walks I've ever taken. To leave a patient's room with hope, with optimism, with a way forward, and to instill that in the patient, okay, to build that trust. And then to come back and actually give the exact opposite message, to say, no, actually, not only can we not help you, but here's the door. I still remember the visual of her leaving through those double doors with her little rolling suitcase. She actually had packed her suitcase because she was ready to be admitted. As I began to look into this problem, what I realized was that it's not just Mass General that had this issue. Back in those days, if you asked 100 ER physicians, how do you treat patients with addiction? The vast majority of them would say, basically, you kick them out. And you tell them, don't use anymore. This is what detox means, okay? We like to ascribe really fancy labels to bullshit treatments. Like this one, it says detox. That's a bullshit treatment. It means just do better and maybe, don't use drugs, okay? 93% of ER physicians used that method as the way to treat addiction. Some of you are thinking, well, okay, what's the problem with that? The problem is that we're killing people with that approach. I promise you, you'll never see a results section of any paper with this drastic of an effect, okay? This is a randomized controlled trial for the epidemiologists and statisticians and academicians in the room. You know this is a gold standard. They took 2 groups of opioid addicted patients. One group they gave medications to, buprenorphine, which, by the way, has a ceiling, so you can't get high, is paired with naloxone, so if you try to inject it, you will put yourself into withdrawal immediately. And it stabilizes patients so they don't actually hit rock bottom, they don't start to withdraw. It's just like if you are a patient who has diabetes, we give you what? Insulin to stabilize your blood sugar and to get you stable enough to maybe go back to the gym and lose some weight, and through lifestyle modifications, perhaps you can shake the medication eventually. But we've got to do something to stabilize you in the interim, right? This is the way to think about buprenorphine. So 75% of those patients in the buprenorphine group were still in treatment and still had no illicit substances in their urine at a year. What happened to the other group, the detox group, the bullshit treatment group? The graph speaks for itself, okay? 0% of them, 0% were still in treatment, and 20% of them were dead. 20% of the group died. So, in case you need a little more evidence, a lot of academics can be just a paper chase, but this academic at Yale, Gail D'Onofrio, is doing some real groundbreaking work, okay? At her ER, she randomized patients to either get medication treatment through buprenorphine or get something a little bit better than bullshit. It's kind of like, we hope that things will work out for you. Here's a couple of pieces of paper that might help you decide where you would want to go. Okay, so compare these two different treatments. And bottom line is, there was no contest. The medication group had a far better 30 and 60-day outcome, with 78% of folks still in treatment. Here's the problem, though. So little old me, I'm a little intern. Okay, at this point, I'm like maybe a month into my first year. I'm thinking, well, the way to do this then is to make getting treatment in the ER easy. The way to do this is to make getting buprenorphine in the ER easy. But the major block, can I just get a quick nerd show of hands? Who knows anything about the DEAX waiver? Okay, you guys are in for something. Oh my God. So check it out. So the federal government created a law that said in order for a patient to be prescribed buprenorphine, which by the way at this point has about 35 years of treatment, of research backing up its effect. In order for a patient to be prescribed buprenorphine, your doctor needs to go through an extra training to be able to prescribe just this one medication. Every other medication, all 25,000 other medications in the formulary, no problem. But this one, we need your doctors to jump through a couple of hoops that we're gonna then light on fire. You have to do an 8-hour course, and you have to pay money. You couldn't design a worse mechanism to change physician behavior or clinician behavior if you tried, right? So nonetheless, this was the problem. This was the state of affairs back then. You know, we had to figure out how we were going to get enough clinicians this DEAX waiver so we could have patients start prescribing, or have physicians start prescribing treatment in the ED. Now, here are the different problems that we had, that we were facing back in 2016. There were 3 different diagnostic subcomponents. The first is, there were very few ER clinicians in our hospital that had a DEAX waiver. As you might imagine, we're asking people to do an 8-hour course and pay money. No one's going to do that. Number 2, we didn't have a protocol in place for medication for addiction treatment. And number 3, as they say, you can't teach an old dog new tricks. Well, try teaching an old clinician new practice patterns. It's even harder. For the purposes of this talk, in the digital health theme that I want to communicate to you, I'm only going to focus on one of these subcomponents. If you're interested in listening or understanding how we address these other components, that's a different talk, but please find me afterwards. Today I want to hammer home this piece around how and why digital health is so important. So back in 2016, we decided to laser focus on this question. How do you get clinicians to go the extra mile and get their DAX waivers? So we started a campaign. The campaign was really cheesily named. It's a dad joke, like very straightforward, get waivered, that's it. The Get Waivered campaign started with a fairly clear mandate. We had only 1 out of 42 of our clinicians who had their DAX waivers. The goal was to get a critical number of these ER clinicians to get their waivers, and to do so without, twisting elbows or using a bunch of financial penalties or making it something that breeds resentment. And so we started a mobilization strategy, which we can talk about more if folks are interested offline. The bottom line is we found the folks who were really interested in this, who saw the value, who had experiences like the one I had with patients and who were fed up. We mobilized them first to get their waivers, and they put pressure on the folks who were in the middle, who were kind of on the fence or maybe apathetic. And of course, there were people who were absolutely against treating patients with addiction. Okay, it's okay. We ignored them. Why? Because it takes a lot of time to try and convince someone who's already convinced themselves. There's a lot of other work we can be doing with people who are kind of on the fence or who have not heard about the issue. So what happened? We had a 2-month campaign, and after 2 months, proud to say, we got 95% of our department waivered. Huge accomplishment. We were the only ER in the country that had this level of DAX waiver saturation in the department. That is a game-changing result. That means any patient just about who walks in the ER almost at any time can be offered addiction treatment. So, I'm feeling pretty good, right? I'm like, my job is done. Feeling good about it. Right? My job's done, right? No, it's not done. Why? Because this is just a drop in the bucket. It's just a drop in the bucket. We helped 40 ED physicians get waivered. Who knows how many ED physicians there are in the entire country? You can just shout it out. Is it like 5,000, 7,000? What do you guys think? 10,000? How many more? 15? It's 48,000. It's 48,000. So, so no, job was definitely not done. 100%, just a drop, literally a drop in the bucket. And so it was time to start to step up and figure out ways to disseminate our model. We worked with the NIH and the NIDA to proliferate this model, to disseminate what we were doing. We were able to partner with a few states like Get Waivered Nebraska to have a whole state-based campaign where we were getting people waivered at the state level. We further refined this model in Get Waivered Texas, which was a really, really fun opportunity. We'll talk a lot more about that. And we took the show on the road. This is like kind of the nerdiest rock concert tour ever. We went basically from like one big academic facility to another doing Get Waivered training sessions with hundreds of people in the audience, and we got lots of people processed that way. It was really exciting. We do 1 or 2 of these courses per month over the course of a year. And now remember the results. Remember the impact of Mass General, okay? So after 2 months, we got 40 people. I was feeling really good. I was like, we're done. We're done here. Well, with Get Waivered Texas, we were getting 40 people per day. So I'm thinking my job is done, right? Like, feeling pretty good. But is it? Is my job done? After all that, we had only gotten about 550 people their DAX waivers. After all that, put on the nerdiest tour. It wasn't like Taylor Swift. It wasn't like Eras, okay? We weren't selling out in the arenas. This was like really, really nerdy. And we only got 550 people through our courses to get their waivers. And so I started thinking, I'm like, how many more of these are we going to have to do? These are a lot of 8-hour courses. I'm like, is it going to be 500 more courses or 750? Or it just felt absolutely impossible. I felt like there's this gigantic mountain that I'm going to have to figure out how to climb. And I was already exhausted, already tired, and we'd only done our Get Waivered Ground campaign for about a year at that time. Nonetheless, my mom never taught me to complain. She taught me to just roll up my sleeves and get in there and do the work. So I did, the good son that I am. And it was like, ready, set. We had a full blitz. I'm talking about full blitz, where we had 5 whole state campaigns planned. We fundraised. We began the hiring process for our in-person organizers and our trainers, and we were ready to go. And all of that was just coming together in January of 2020. And for those of you who maybe remember what happened in March of 2020 that year, that whole plan that we had for in-person, hundreds of people in a room, waiver training classes across 5 different states. It was like ready, set, go, okay? That whole plan was now null and void. All of it was basura. I mean, there was nothing we could do on this. And yet, we had a decision to make. Do we stop doing what we're doing? Do we just sort of say, well, it's over? We tried. We came up with a plan, and it didn't work. Or do we say, actually, no, this is the reason why we now need to double our efforts. Why? Because addiction treatment facilities were closing at the time. It was hard for patients to go to an addiction center because it was closed. So where are they going to go? To the ER. And so maybe actually this is even more reason for us to be doing what we're doing. So the destination didn't change. We realized we still have to get thousands of people waivered. But maybe the vehicle had to change. And this is where digital outreach, digital tools saved the day for us. So we had to completely pivot. In the span of about 30 days, we begged, and by beg I mean like on our knees, pleading the accrediting agencies to allow us to do these X-waiver trainings, not in person anymore, but via Zoom. It had never happened before. The accrediting agencies said, well, first of all, actually, it was at the time where no one used Zoom. Can you guys still remember that? There was like this time where no one used the Zoom. They were like, what is Zoom? We don't trust that. So, they were sort of looking at us suspiciously as if, well, what are you trying to do with these waiver courses? They had a lot of trepidation around this. But eventually, they gave us the license to be able to do the first ever X-waiver training via Zoom. We began prepping for that first ever X-waiver training, and we began doing a bunch of digital amplification events to try and just drive traffic, as much traffic as possible, to our X-waiver courses. We changed our whole model, and we had to ask a new question. The new question now, because of digital, because of the ability for reach and penetration that digital tools offer, the question was no longer which states do we partner with. It was now like, no, but seriously, how many people can we get onto a Zoom? Very fun. And so we created a funnel. When I say funnel, do folks know what I mean by that? Because I don't want to have to. Yeah, okay, great. So it's just a funnel, right? At the end of the funnel is we want people to sign up, clinicians to sign up for our waiver course. We had a whole bunch of things at the top of the funnel. We had influencer campaigns, we had ads on Instagram, ads on Facebook, blog posts, pushing everyone that could into our courses. And this is what happened. This is the first pilot that we did. You're seeing our Google Analytics from that first waiver training class. I mean, it was explosive. In May, in less than a month, we got 10,000 impressions on our site. Over 400,000 unique page views on the blog posts that we were working to get people signed up for our course. And just in that one course alone, we got 1,200 people to sign up for the waiver. 800 of them actually showed up and did the whole course with us, 8 hours. And then 527 people went all the way through and got their DAX waivers. In one 8-hour course, we spent a year doing the nerdiest tour in Texas, and we got 500 people. This is in one 8-hour session. The coolest thing about this was that by using a digital platform, we were able to then, in the middle of the course, recruit other people to join our next course. So every course we had was an opportunity to recruit more people, because we asked people while they're in the course with us, getting their DX waiver, please tweet about it, please put it on Instagram, because we want to normalize this idea of getting a DX waiver, that physicians should do this, that it's important for your patients, and that you can be talking about doing the right thing till you're blue in the face. Show us action. Show us action. This is action. Other cool thing about it was, it was really flexible. Instead of having people show up to a course and take it for 8 hours and sit there, people could stay at home. This is Dr. Jasmine Shaw, who was an ER physician, ER clinician at the time. She had just had a kid. Had we done an in-person course, there would be no way she could bring her baby to an 8-hour course and have a intelligible 8-hour course that wasn't interrupted. So she was able to do this at home and get her waiver and show others that this is the right approach that we ought to be taking. As I mentioned, we work with influencers. These are folks who are physicians or nurses who have really big platforms on social media, on Instagram, on Twitter. We had a whole X campaign, which is, again, really cheesy, I understand. But it got the word out and got other clinicians to want to care and to want to get signed up to get their X waiver. In essence, this pivot to a full digital strategy was a little bit like riding a bike your whole life, feeling like you're going pretty fast, and then one day someone puts you on a rocket ship and you're like, oh, I'm never going back. It was this incredible, incredible opportunity to see the power that digital tools, if used effectively and responsibly, can have at changing the face of care in our country. And so after a couple of years, we had lots and lots of Get Waivered courses. We partnered with a whole host of organizations like YouTube Health and the University of Michigan and the VA Department of Public Health, Virginia Department of Public Health. And after about a year and a couple months, we got just over 5,000 people newly waivered. Feeling pretty good, like 5,000, it's pretty, But no, right? My job still isn't done. We got 5,000 people waivered. Does anybody know how many clinicians there are? I think maybe you saw it, I don't know. Anyone know how many clinicians there are in the country? Hundreds of thousands. 600,000. 600, okay. 1.8 million. My job's not done. And so really, at the end of the day, again, this is a drop in the bucket. Now, this story has a really good ending, and also, it has a challenge for everyone in this room, okay? In December of 2022, the President signed the MAT Act, which is basically, it's an act that makes getting medication for addiction treatment dramatically easier. One of the key provisions in the MAT Act was the dissolution of the X waiver. Thank God. Finally. So now, every single clinician in this country can prescribe buprenorphine. Okay? That medication, the one that we saw, remember, don't ever forget about that graph I showed you, okay? That difference. That medication that gives people access to their lives again, for many, now 1.8 million clinicians can prescribe that medication, which is absolutely huge. But the challenge now is, how do we use digital tools to upskill that new found cohort of clinician prescribers, and also to do it in a way that does not worsen or widen healthcare disparities. So the view from the frontier of digital health and the opioid crisis looks beautiful. There's a lot of interesting things happening. There's a lot of exciting progress that we're right on the cusp of. Here are a couple of things. Number one, the Philadelphia Department of Public Health is working with Penn Medicine to expand virtual bridge clinics. These are really low barrier points where patients can get access to addiction treatment via telehealth, which is great. By the way, I have no conflicts of interest to disclose. These are just really important innovations that are happening. Boulder Care is a company that offers on-demand medication for addiction treatment, again via telehealth, making it really easy for their patient population to get access to treatment via video messaging and chat functions. And then lastly, Ophelia, which just closed the Series B round, similarly is expanding a telehealth-centric model to make it easy for people to get addiction treatment. Now, that is all well and good. I support these efforts. I think these are absolutely steps in the right direction. But if this is all we do, we're going to be in trouble. Why? Because telehealth has the potential to widen healthcare disparities. I'm going to say it again. Telehealth has the potential to widen healthcare disparities. Why? We live in a country still where nearly 20% of the population does not have access to high-speed internet. And those percentages get worse when you look at the elderly. They get worse when you look at black and brown communities. And so if we're not careful, all of those cool, awesome interventions here, they're going to be only centered on giving access to one part of the population while we leave behind another. On top of that, even before we added telehealth to the mix, there were already pre-existing gaps in access to opioid addiction treatment. These are just a couple. I mean, there are study after study after study that show these are just a couple, okay? The first was a study looking at black patients compared to white patients, both with opioid use disorder. The study in JAMA found that black patients are 77% less likely to receive medication for addiction treatment. What do they receive? That bullshit treatment I told you about. Here's your paper, get out the door, detox, okay? Similarly, this study in pediatrics found that black youth with opioid addiction are significantly less likely than their white peers to be prescribed buprenorphine. That's about 40%. So if we add the potential effect of telehealth, right, the effect of folks not having access to high-speed internet or broadband, these numbers are only going to get worse. Okay, but it's not all doom and gloom. There's a potential solution here. Can I ask, real quick, before we go forward, how many, because this is also going to be kind of a review of my job before I came back to academics. How many of you in this room, by show of hands, have heard of the Affordable Connectivity Program? Okay. Okay, so for the viewers at home, we got like 6 or 7 people. Okay, so I've got to do more work. So the Affordable Connectivity Program is a program that helps patients connect to broadband and high-speed internet. My former boss, the Vice President of the United States, was very fond of saying, when people are cut off from high-speed internet, they're cut off from opportunity. It's no longer a nice to have high-speed internet. It's a must-have. So the bipartisan infrastructure law included in it this really secret, sort of almost sneaky provision that I wish more people knew about, called the Affordable Connectivity Program. It's $14 billion of funding that goes directly into the pockets of low-income patients. I mean, that's just great. No one fell off their seat? No one? Okay, well, how about this? On top of that, there's $40 billion that goes to governors in this country to help rebuild the broadband infrastructure, or build for the first time in many states the broadband infrastructure of those states. That's like discretionary funding. So what is the Affordable Connectivity Program exactly? The Affordable Connectivity Program gives low-income households up to $75 a month to pay their internet bill. Okay? They can take that money and they can give it to Verizon to pay their bill, or Comcast, or T-Mobile, or Mint. If they have Mint, they have other problems. Forget Mint. They could use their phone. They could get home internet. They also get on top of that $100. Okay, $100 to pay for a tablet or a computer or a new phone. Now here's the problem with this. And by the way, how do you qualify? You qualify by having one of these things, one of these criteria. So Medicaid, SNAP, WIC. But here's the cool trap door. Even if you don't have one of these things, if someone in your family, in your household, has Medicaid, or has SNAP, or has WIC, you qualify. Okay, so let's just get some numbers. How many people out of 100%, okay, 100% eligible people in this country, how many people do you think, in a percentage, have signed up for the ACP and are currently receiving money? 2%. A fraction of a percent, okay. 1%, okay. It's not that bad, but okay, you kind of took the room out of the air out of the point, but you get what I'm saying. Literally 30% of patients, 30% of people who are eligible have signed up. That means that 70% of those who are eligible have not signed up. But here's the one that I want to highlight for the healthcare spin and the healthcare theme in this conference, okay? Remember what I said earlier. If you have Medicaid, you automatically qualify. If you have Medicaid, you automatically qualify. So why isn't everyone on Medicaid signed up for this? Only 12.9% of those who have Medicaid have signed up for the Affordable Connectivity Program. And so what we do with Link Health at our hospital, at Mass General Hospital, in our surrounding community health centers, we're not waiting for someone to come around and sign all these patients up. We are going out of our way to make sure that we make it easy for patients to sign up. We embed ourselves in waiting rooms. We have a virtual program where we text patients. We have posters and handouts and discharge paperwork that make it really easy for patients to sign up and receive the money that, by the way, was meant for them. It's really not that hard. We have some preliminary data over the course of the last couple of months. This is actually more recent. This is like as of, I think, June. We've screened about 1,600 people for ACP eligibility, and we've distributed about $77,000 in yearly funding. As you might imagine, the vast majority of the folks who we've signed up have Medicaid or Mass Health, and the vast majority of folks who we've signed up are Black and Latino, mostly because we're in an urban area. But I promise you, the same fundamentals of this program will work in a rural community where I would argue probably the digital divide is even worse in those communities with all the rural hospital closures we're seeing around this country. And just recently, about a week ago, we were in the Boston Globe for this work, telling the story of one of our patients who was signed up and who's now receiving internet, who's getting this money for internet, now has a computer and internet for the first time. It's transformational. It's not just about telehealth and telemedicine. It's also about this person now being able to apply for federal benefits. It's about them being able to apply for a job. It's about this person being able to now communicate with their relatives. And so I want to leave with a couple of calls to action. One call to action is next Friday, there will be a whole healthcare-specific White House ACP Week of Action, okay? The White House is bringing together hundreds of organizations, influencers, organizations and companies, things like that, to get the word out about the ACP because, as you all know, it's critically important that people get access to this funding. And if we don't use it, we're going to lose it. And there's lots of patients who are probably being served by your organizations that could benefit from this money. So if you are interested in joining us to spread the word about the ACP, we've made it really easy. You can just scan that QR code and join us on this day of action, which is next Friday, June 16th. Again, I think we could have hundreds of thousands of people who get signed up for the ACP on this one day. If healthcare really put their shoulder into this and really did this, we could distribute millions of dollars in ACP funding. And it's, look, I'm all about doing the right thing for people and doing it because it's the right thing to do. This is an economic win for healthcare. This is an economic win. What did COVID show us? COVID showed us that basically we had to start using telehealth in a much more robust way. And telehealth is now a mechanism of action, a mechanism of providing care like it never has been. And if we're not careful, we're going to leave behind patients who can't access telehealth. But let me make one other economic argument. I was just talking to an insurance company about this work. We're helping them sign many of their patients up for the ACP. The biggest problem this insurance company has is the following. They have a very high-risk group of dual-eligible patients. When something goes wrong for that patient, oftentimes the patient doesn't know better. They go to the ER. It's a $3,000 visit to come and see me in the ER. Oftentimes, they don't need to see me in the ER. Oftentimes, that knee pain could have been teleprescribed some naproxen in a lidocaine patch, and they can just stay at home. Or that albuterol prescription could have been refilled via a chat prescribing interaction. So this insurance company says, well, our big problem is that we have these patients who are reflexing to the emergency department. We'd love it if they could use our on-demand service. I said, okay, well, how do they access the on-demand service? Oh, well, it's on their phone. Okay, well, what if they don't have a phone? Well, then, okay, well, what if they have a phone, but they don't have internet that's stable enough to sustain the video chat that you need them to do? So this insurance company is really, really, really interested in trying to figure out how do we make sure that our patients get access to internet, get access to home internet and broadband and computers to undergird the whole system. So I'll end with, I still to this day, I don't know what happened to that patient that I took care of when I was an ED, little bitty intern back in 2016. I don't know if she actually got her life back. I don't know if she got treatment. I hope she did. I think about her a lot. What I do know is that we have an opportunity here and now to remake the face of addiction care in this country. With tools like the digital health tools we talked about here, with the funding I just talked about through the ACP, we can make sure that we remake that whole care pathway, but do it in a way that does not widen the disparities and leave people behind. But it's up to us now to put these pieces together and to get the work done. With that, thank you very, very, very much, y'all. My email's here. Thank you so much for inviting me.
I have a question.
Please.
First off, thank you so much.
Yes.
And the reason I knew Man's Grace Hospital was at Brigham.
I'm sorry to hear that. I'm joking. So in emergency medicine, we have to train at both as residents. So I spent a lot of time at the Brigham.
Okay.
So.
My husband, Joe, when I was there, I was the CIO there for 12 years.
Oh, wow.
And he switched to BMW and he said, world's best hospital. So.
There we go. There we go.
Anyways, thank you so much for what you're doing.
Of course.
And I said here to my colleagues, seeing you and what you're doing and what you've done the last few years just gives me hope for the future, your generation and the ideas and the energy.
Oh, thank
My
you.
question for you is, besides, ACP and amplifying that somehow, are there other ways that people in this room can help amplify some of the work that you're doing?
Yeah. Oh, wow. Great question. I mean, the big thing I would say is to make it easy, that White House Week of Action for the ACP is really, really, really important. Why? Because if we don't use that money, if patients don't get access to it, they're going to miss the boat. It's not clear what's going to happen. It's possible that the ACP will go away by midsummer of next year. But for patients who are signed up for it, they'll be grandfathered in, likely grandfathered in. So the goal is to get as many people on as possible now. So I would say that's the first thing. The second thing is, if you have ideas of how we might be able to work together, the important thing I just want to share is we've got to find opportunities that advance health equity, but do so in a sustainable way. It can't be charity care, okay? It can't be we're taking care of health equity because it's the thing to do that's in vogue, okay? It has to be, advancing health equity is actually critical to our mission, and we see how and why this helps undergird all of our efforts. So if that's you, and if that's your organization, let's talk and figure out how we can work together. But I am at the point now in my life where I do not need any more performative health equity. You guys know what I'm talking about. The Black Lives Matter email and the hashtags. I'm good. But if you're trying to actually get to work, let's do it. Let's talk. That's my email. Any other questions?
So thank you. This has been fantastic. I actually have a lot of questions, but they're very specific. I'm working on a program for the ACP for Western Massachusetts.
Awesome.
Believe it or not. So this is
perfect.
And the Alister Martin. And so I was not fully aware of the scope and scale as you presented it here. And it's in partnership. The Vice President of Community Affairs at Himss Health is the champion of this. So it is something that there are programs, there are grants in the states that are coming out and about. And so I absolutely look forward to vetting your event and hearing a bit more about what you've done so far. We are just nascent in our formulating our approach and how to make this happen.
Yeah, thank you so much for saying that. First of all, we don't have all the answers on this with regard to the ACP. But what I do know is when we work together, when we stop the lone wolf thing and where this organization does that and this one does that and this one does that, when we break those barriers down and share information, share best practices, that's when we make 1 + 1 = 3. So really would love to work with you and figure out how we can get that done. We have one more question here.
Are you working with HHS in Massachusetts on this already?
Good question. Yes, I'm working with HHS Federal.
Okay.
The regional offices know about the ACP, and they're pushing this through the federally qualified health clinic system, which is the most that they can do. They can't, well, they can do more, but they've got a lot of other priorities.
Kate Walsh,
Yes.
HHS now, she's taken everything she's done in her career in EMC and brought it to the state level, which is so wonderful. So leveraging, who's in that office too here in Massachusetts.
Yeah, that's a really good point. And if you have a connection,
I do.
there we go. I love it.
Yeah, it's kind of a fun question, which
Yes.
is, when you were talking about your influencer campaign,
Yeah.
did you think at all about working with celebrity physicians or actors who play physicians?
That's a really good question. Oh my God.
Well, I just
Such
want
a
to
good
finish
question.
it out by saying too, like, additionally, had you thought of integration into storylines with Hollywood scriptwriters? I'm just
Man.
wondering, and then the fun part is, if you had your ideal, what storyline and what show?
You should contact Shonda Rhimes. She always does that. She takes real life events and puts them into her storyline.
The scene starts. A young, frustrated ER physician has just intubated his third patient in the middle of the COVID pandemic. And the vaccines, thankfully, have just come online, but the pandemic is still surging. He walks into a room of a Spanish-speaking patient, and he has a flashback back to the last 3 patients he's just intubated. They're all Hispanic as well, or Latinos. And he tells the patient that it's important for him to get a COVID vaccine. And the patient says, yes, doctor, I will do that, but how do I do that? And the doctor says to him, well, you have to go online to schedule your vaccine appointment. And is an elderly Latino man. He says, well, I don't know how to do that. I don't have access to, an internet at home to do that. Can someone help me? And the doctor, frustrated, says, this is why the last 3 patients who I had to intubate were Latinos. Because the access to the treatment, to the thing that would save the patient, actually has an activation energy, a barrier that is hard for many of these patients to overcome. And so he wishes and hopes that there was a resource out there to help patients get access to internet and put money in their pocket to pay the internet bill. And then someone taps him on the shoulder, tells him about the ACP. What do you think? Is that okay? It's not bad. I haven't thought about it at all, really. I haven't thought about it at all. No, but if you have any connections to, yeah, I've definitely thought about, celebrity doctors. The one that we really got to get is Meredith Grey. Yes. If anybody has a contact with Ellen Pompeo, let her know that there is a bald guy who looks like a Ninja Turtle in Massachusetts who is really looking to speak with her. No, do you ask for a particular reason? Like, do you have ideas? Also, if you have ideas, we love those as well.
I was just thinking about the ages ago, the campaign with scriptwriters to encourage seatbelt wearing.
Oh, wow.
And, I mean, this was 80s, 90s. But I think, yeah, 80s. So if now that you notice it, or now that you hear about it, you might notice almost always on a TV show or in a movie when someone gets in a car, they put on a
that's so
seatbelt.
interesting.
And that wasn't by accident, because there was a very coordinated campaign through the Harvard School of Public Health to do exactly this. It was like a designated driver campaign. So,
wow.
I was also thinking about some of like the celebrity awareness work that I'd done, and it just, the cross X, it just seemed so perfect to have,
yep.
And again, but is it? Because then do you move it into maybe a realm that's not quite as serious, or that makes light in a way that is for entertainment value? I mean, it's a fine line, so it is a curious question, like where do you draw the line on influencing as it butts up against entertainment for the purpose of massive behavior change?
Yeah. But it's interesting. It's like you can't get there without that. I think if you're really interested in changing hearts and minds, you have to get into the culture. So I think your point is very well taken.
Quick question. So I listened to you talk about volunteerism and the places you can go on to kind of push the information out to the community. But have you looked at community volunteers that could actually are living the life that these people are living, that could actually go and help go to that elderly Latino patient's house and help them fill out the information, whether it's via an iPad or some other way?
Yeah, that's a really good question. What you're talking about is something called relational organizing, right? Like that the best messenger to communicate a message is actually often not me, the doctor. It's someone in their family or in their community or a friend that they trust already. So it's a great point. We haven't yet, mostly because of funding, because we have to pay them for their service and for their work. What we have been able to do is recruit and train students, medical students, nursing students, undergraduate students, to be ACP sign-up experts. And then we distribute them, we disperse them in community health centers. They knock on doors in low-income communities like Dorchester and Roxbury, and they're doing it. And then the last thing that we do, which I think is close to what you're describing, but not exactly it, everyone who we sign up for the ACP, it's kind of cheesy, we give them a prescription for internet. And then that patient takes that prescription for internet and gives it to one other person in their life, and then it has a QR code that they can then call us and we sign them up. So we try to make the chain, but no, it's nothing as sophisticated as you've talked about.
Hi, thank you so much for your discussion and just bringing awareness to this issue.
Yeah.
I had a question, I'm not sure how much you would know, but once people sign up, are you hearing feedback that it's then harder, or not harder, but hard to get the actual service set up, like them going to Verizon,
Well, that's a good
or
question.
Comcast, or whoever to actually use the credit that they're given?
That's a really good question. Yeah, that's a very good question. So there are a lot of answers. Let me try and be concise. So the first is, we don't, this is recorded, right? Okay, all right. So let me use different words. We do not trust the ISPs, the internet service providers, farther than we can throw them, and we can't throw them that far. So we do frequent chase, it's called chase. After someone's been signed up, we text them again, we call them again, we make sure that they actually receive the benefit. So we have a chase program afterwards. And then the other thing that we do, is this camera recording? The other thing that we do is when the ISPs mess up, we go to the FCC complaint line and we report them. We let them know, like, hey, this regional provider of broadband has routinely dropped customers or has not accepted the ACP benefit, even though federally they say they have. So we make sure that there's a mechanism to report bad actors too. So yeah, we try and handle the problem at the individual level, but then we try and also, when necessary, kind of raise the flag and say this person or this group is not working as well as it should. Okay, drinks? Is that what's happening right now? Is that what's happening? We could do one more, or we could all get shots. I mean, I don't know. Okay. Thank you all. You know how to reach me, and looking forward to talking with you afterwards. Thanks.
I'd like to thank you all for coming today. We have a few housekeeping items, and then we will get everybody out the door to our cocktail hour. The first is we would like to thank E-Inc. for participating again in our scholarship. And I have John Marksenko here to present our scholarship. Did I do it? I know, and yes, still I didn't get it. So I'd like to turn it over to him, who's going to announce our winner this year.
Hi, everyone. I'll make sure to do this quickly so I can get you guys out of here. So my name is John Markesano. I'm with E-Inc. E-Inc. is beyond thrilled to be sponsoring the scholarship for the second year in a row. So I would like to invite onto the stage the winner of the 2022 to 2023 New England Himss E-Inc. Innovation Scholarship, Kristen Siseski. Kristen currently works as an OT and a certified hand therapist at Yale New Haven Health in Connecticut. In 2019, Kristen was offered an opportunity to join and co-chair an EPIC optimization committee for her health system. She quickly realized she found satisfaction and joy in helping clinicians improve their efficiency in documenting within their EHR. After over 20 years of direct patient care, Kristen was ready for a new professional challenge. She researched degrees that would best blend her love of patient care with her new interest in developing EHRs to better serve both clinicians as well as patients. In the spring of 2022, Kristen enrolled in Charter Oak State College's Health Informatics Master's Degree Program. Kristen finds the course content both interesting and challenging, as she is new to the technological side of healthcare. Following graduation, Kristen plans to apply for positions that will allow her to use her experience as a clinician as well as her knowledge in health informatics. At this time, please join me in congratulating Kristen on the scholarship.
We'd also just like to acknowledge and recognize our student poster contest winner, Bhargav Patel. We wish him congratulations. I hope you all had a chance to take a look at him, so thank you. And now we're going to do some raffle drawings. We have quite a few, so just be patient, and then we can get on with our cocktail hour. Is Data Prize here? Yep, come on up. So we have several raffles from our sponsors, and they're each going to announce the winners for us.
Hi everybody, I'm Dave Brunel, and we were giving away a Yeti cooler, and it'll be shipped by corporate out of Maryland, and Irene Chen is the winner. Irene, you can get an email tomorrow or Monday.
Thank you. Next up is Healthcare Triangle. I'm going to be presenting for them as my CATA lead today. And the winner of a Bluetooth device is Carlton Gebhardt. Come on up. Thank you. Next, we're going to be announcing Connection. Are you guys here? So here she comes. Thank you.
So for our giveaway, we have 2 sets of Yeti tumblers, and our first winner is Matt Derrico of Lawrence General. Matt's not here. It's all right. We'll get it to him. And our second winner is also Irene Chen. Sorry, she's taking the camera.
Thank you. You're the big winner today. There you go. Wolf and Company is, where's my fun? Here it is.
An Amazon gift card for Joe Deaver from Holyoke.
Thanks, Doug. The next is Queen Consulting. We have a lot of generous sponsors.
Hi everyone, I'm Jessica Zwillinger. I work with the illustrious Katie Bethel at Queen Consulting Group. Our gift card is from Amazon, and it's going to Mahesbin Munchie from Mass League of Community Health Centers.
Next, we have our conference survey from New England Hymns. It is a $100 gift certificate to Amazon, and our winner is Caitlin Flannery. And last is LK. Do we have someone from LK?
Hello, everyone. So I'm Jordan Hode from LK. We're the B company. So the proud winner here for a $100 Amazon gift card and some of our beautiful honey goes to Daniel Neves from Tufts.
Next, we have one final drawing from InterSystems.
So thanks so much, everybody. So this is a $100 gift card for Irene Chen at Boston Children's.
Everybody needs to hang around with Irene later today because she's apparently pretty lucky. So that wraps up our drawings. Again, oh, one more? Okay, there you go.
Hi, Yasa from Parent Consulting Group. I know, right? I mean, well, I haven't drawn yet, so let's see. It's a lovely Bose waterproof speaker, great for the summer. And it's going to David Mankey from Tufts Medical.
I'll
see him tomorrow. Seriously, he works.
So thank you everybody for attending today. We hope you enjoyed the conference, the good food, the networking, our wonderful, wonderful presentation. Thank you again to all of our amazing sponsors, and also a special shout out to Elisa, our administrative director, who without this, to every little detail you can possibly think about and not remember, she does. She's awesome. We love her. And we ask you and invite you to our wonderful cocktail hour. We have a photo booth, we have jazz music, and plenty of good food and drink, so please join us out for that cocktail hour. Thank you.